Welcome to the Neurocritical Care Society podcast. My name is Joshua Levine. In this episode, Dr. Ramani Balu will interview the well-known, prolific, and accomplished intensivist Dr. Mauro Oddo about a paper he recently published in Annals of Neurology entitled Early Prediction of Coma Recovery After Cardiac Arrest with Blinded Pupillometry. Enjoy.
Dr. Oddo, welcome to the Neurocritical Care Society podcast, and thank you for taking time to sit down with me and discuss your recent paper in Annals of Neurology that describes the use of automated pupillometry to predict neurologic outcome and coma recovery after cardiac arrest.
Well, thank you for the invitation.
As someone who takes care of cardiac arrest patients, I can attest to how hard it can be to provide an accurate picture of the potential for neurologic recovery in a patient that's post-cardiac arrest. As you state in your paper, it's generally accepted that post-arrest neuroprognostication should utilize a multimodal approach. So for our listeners, can you briefly describe what is meant by using a multimodal approach for outcome prediction after cardiac arrest?
Yes. So based on recommendations, guidelines from several societies, by multimodal, we mean adding at least another modality to clinical examination. So first step, always neurological examination, particularly the pupil reactivity and corneal reflexes. So it's basically brainstem reflexes. Motor response as well, but that's step number one is clinical examination. Amongst modalities, you normally distinguish between electrophysiological assessments, EEG, how the EEG looks, discontinuous, suppression, the reactivity of the background, and then somatosensory evoked potentials, the response of the N20 median potential. And then you have biomarkers, and most studied is the neuron-specific enolase. And then you have brain imaging, looking at the extent of injury in the brain. And so what is recommended is to apply this multimodal assessment, and this is particularly true for patients who, of course, do not wake up within 48, 72 hours.
So what are some of the shortcomings of this approach?
Well, I think the first shortcoming, if you start with neurological examination, is pretty amazing that even though is pupillary reactivity, pupillary response, symmetry, size, in terms of neurological prognostication is number one. But if you think about it, we don't have a number. We don't have a quantitative score. So you say that the pupil is absent versus present. And when you think about it, it's very imprecise, especially in patients with critical care conditions, opioids, and other definition includes sluggish. So it's actually strange, but you don't have a score. The second thing is electrophysiological examination. So EEG in publications is quite powerful, but the reactivity is not standardized. Evoked potentials, when you say that bilateral absence, but can be present and then you don't know. So the sensitivity of many of those tests is relatively poor. And then you have availability. So it's not available everywhere because you rely on neurologists. So if you work in a general critical care facility, you may not have the neurologist available. And then the biomarker, we have seen over time that you don't have a precise cutoff. And then you need to have a laboratory. So if you consider everything, I think what we lack is a quantitative tool, which is simple to use, is not dependent on laboratory or the availability of the machine. And then even more would be good to have a blinded assessment.
Yeah, another thing that I wanted to talk about before we get into the meat of your study is this notion of the self-fulfilling prophecy bias, which you kind of brought up when you were talking about some of the limitations of a multimodal approach to neuroprognostication. What is the self-fulfilling prophecy bias, and why is it a problem in post-cardiac arrest prognostication?
Well, the self-fulfilling prophecy, by definition, is that you rely on a test which you believe will give you a definitive answer. So, for example, what is considered the gold standard for poor prognostication is when your somatosensory or potentials are bilaterally absent. But if you have this test, which is negative, you say, okay, this patient will not recover. But you never wait, let's say 4 weeks, 6 weeks, which would be the ideal trial, which of course will pose ethical issues. So that's the point. So it's a sort of a prophecy because you know already evoked potential bilaterally absent. Also, the fact that all those tests are not blinded. So the withdrawal of care, you do it because you know that the test is negative. So you say to yourself, well, the test is negative, so I can be confident enough.
Yeah, this issue keeps me up at night when I take care of patients who have suffered a cardiac arrest. And it was really driven home for me last year when we had a patient in our neurointensive care unit that, for a variety of reasons, had her neuroprognostic evaluation delayed by a couple of weeks and ended up having somatosensory evoked potentials performed 3 weeks after her cardiac arrest. And the N20 response was negative bilaterally. But because of the family's cultural and religious preference, they chose to continue with aggressive care and not withdraw care. And 2 weeks later, that patient woke up. And it's a sobering thought to think that our preconceived notions of what we think a test is telling us may inadvertently not allow someone to have a recovery. And your paper, I think, very nicely tries to get around it by using a different approach to get some information about prognosis and blinding the investigators as to the information. And specifically, you utilize automated quantitative pupillometry. Can you describe this technique for our listeners and the rationale that you had for using it in your study?
Yes, so it's a simple tool. So it's sort of a lamp that projects a calibrated light stimulus. So the advantage is that the stimulus is always the same. So the light doesn't vary. And then the tool, the device is able to, with a video, so it's in infrared recording. So you basically put light in a pupil, and then you have a constriction. So this device is able to measure several variables. So the one we report in the study, which is probably the strongest one, is the pupillary light reactivity, so the percentage constriction. Then you have constriction velocities, you have other variables. There are two devices. So one is basically addressing the percentage reactivity. And then you have another device which combines all these variables, adjusts for the pupil size, and give you an index, a scale, in between 0 and 5.
And so how was pupillometry exactly used in the design of your study?
What we decided to do is to continue on our multimodal approach, which is described, and that's what we discussed before. In parallel, you have a team which is not involved in patient care, that performed the pupillometer. So the pupillometer was not entered in the bedside patient information. And so that's the blinded approach.
And for those listening to the podcast who are trainees or in early stages of a clinical research career, I think it can be very helpful to hear about some of the behind-the-scenes challenges to getting research studies off the ground. Can you identify any particular challenges or surprises that occurred as this study was performed?
I mean, for this particular study, we did not, since it's not interventional, it's an observational trial, the tool is non-invasive. So when you do clinical research in such conditions, generally, the ethical approvals are relatively easy to obtain. For the study, it is true that we relied on a small group of people that has good experience on how to use the pupillometer. And again, the effort is just to collect this data, but the tool is very easy to use. So in this study, that was really pupillometer used by nurses and as a simple tool. So it's really an example of easy clinical research, if I can put it this way.
Can you briefly summarize the results, the salient results of the study for our listeners?
Yes, I think that what we found is the pupillometer is very strong in terms of prediction. So it has the same performance as electrophysiological examination, which could be considered maybe standard if you think about multimodal and numbers. There is Very good correlation, strong correlation between the pupillometer and the neuron-specific NLAs. So you know that when the pupillometer at day 2 is low, there is brain injury. So it's also a way to quantify the severity of post-anoxic brain injury. So there was really a good value of this tool to quantify the severity of injury, and it has the same prognostic performance than an electrophysiological tool. So if you have an abnormal pupillometer, you should start thinking this patient has a severe brain injury.
So one specific question I had about the results is it seems that pupillometry robustly predicted outcome in these patients, irrespective of the amount of sedation that they had. That is a non-intuitive result for me because a lot of sedative medications can affect the pupillary response.
Yeah. Yes. Well, we should add here that the prognostic performance of the pupillometer was at day 2. So at day 2, patients were not sedated. So sedation and especially opiates, so fentanyl, was stopped. Now, the pupil size did not differ between non-survivors and survivors, and the amount of sedation in these patients is also standardized. So we have a standardized sedation protocol that goes together with the temperature. But you should rely on the test when a patient is not under sedation, so it's 48, 72 hours, and generally sedation is stopped. But the amount of sedation was comparable between the two outcome groups.
Okay, thank you for clarifying that. Were there any features, apart from what was reported in the paper, between survivors and non-survivors that suggested that in some way non-survivors are sicker? Do non-survivors have, for example, a higher lactate or more hypotension or a larger Apache score when they come in? And is there some other feature of their systemic illness that also predicts whether or not they're going to do well?
Well, that's something that we studied previously, but of course, blood lactate, especially the blood lactate clearance. I think the strongest non-neurological variable is the duration of cardiac arrest, and especially if you have the no flow, low flow times, the type of rhythm, of course, ventricular shockable versus non-shockable. In terms of severity, the one which is validated in the post-cardiac arrest is the SOFA score, more than the Apache 2. And then we also studied in the past the procalcitonin, and we published that elevated procalcitonin is a marker of mortality. So there is, of course, an association, but you can calculate the duration of cardiac arrest, and among survivors, I can tell you, you have patients with long durations, you have patients with elevated lactate, you have patients with asystole. So you cannot stop care based on these non-neurological variables.
Yeah, no, I think that's definitely true. Based on the results of your study, how should I view the role or the expanding role of pupillometry in outcome prediction?
If we talk about cardiac arrest, I think the pupillometer, it should support, now can we say replace, but definitely support the pupillary examination and gives you a number that you can follow up. Now, you have prognostication, and these data on cardiac arrest are relatively strong. We could see the same in terms of other neuropopulations, traumatic brain injury, for example. And then there are lots of other potential indication of clinical research studies that we are presently conducting in Lausanne. But right now, I think that it's something that you could use at the bedside to follow up these patients, see in terms of prognostication, and potentially to follow up for secondary insults.
Yeah, so to follow up on that, quantitative pupillometry is clinically available. It's not a research tool, and it's becoming more and more widespread in its use in neurointensive care units and critical care units all over the world. Based on the results of your paper and other papers, I suspect that the use of pupillometry is going to grow. Do you think it's ready for prime time and ready for widespread adoption with providers that may not be, say, as trained in the proper use and interpretation as your study team is? And if so, are there any pitfalls that you foresee as we move on in the future? So,
to answer your question, as every tool, monitoring tool, you must have an algorithm. So let's say I think it's ready for use for prognostication after cardiac arrest, integrating pupillometer in your multimodal approach. That is something that we are considering starting at our center. For other applications, we need additional data, and I think they will come in the future. Let's say you have asymmetry. Now, okay, are you going to perform a CT scan on every patient? That could be, time consuming. So I think we need additional studies. We need to identify maybe some patient subpopulation, those with abnormal CT scan, with contusions, where the pupillometry may predict that things are going wrong or in the wrong direction. Maybe integrate pupillometer for the prognostication of TBI neurorecovery. Other potential explorations may be available for neurocomplications in general critical care. But I think in those other areas, we need extra clinical investigation. And for past cardiac arrest prognostication, we need integration in algorithm as for every monitor, because, you have a monitor, you need to write down how to use it.
Yeah, I think that makes a lot of sense. So I'll end with just one last question, which you kind of touched on earlier. You astutely commented in the discussion of your paper that, quote, with respect to poor prognosis, to know exactly how pupillometry data would correlate with clinical outcomes, the study would have to require that no patients have care withdrawn. And so the self-fulfilling prophecy is therefore partly but not fully addressed in our study. So, the lack of the ability to provide unbiased prognostic decisions strikes me as a fundamental problem, not only in post-arrest care, but in almost all of neurocritical care in general. Do you see any way of getting around this?
I will provide you a philosophical answer. There is always part of something that we don't know and we cannot know. So philosophically, you cannot get rid about self-fulfilling prophecy. What you can do, and this is more a scientific answer, is to be as close as possible as to the truth. But there is always something that sort of you may miss, because this is part of the surprise, and the patient you described is an exception. But in the large majority of conditions, at least in cardiac arrest, we have reduced the sort of gray zone. So we provide precise answers based on several tools. And I think the pupillometer helps in providing these precise answers. But philosophically, you cannot get rid of the self-fulfilling prophecy.
Dr. Oddo, thank you so much for spending some time with me today and talking with us on the Neurocritical Care Society podcast. It was a real pleasure.
Thank you.
This podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. The Neurocritical Care Society provides and advocates for the highest quality of care for patients with critical neurological illness throughout the world. Follow us on Twitter @Neurocritical, on Facebook, or visit www.neurocriticalcare.org for more information about NCS and the comprehensive resources that it offers. On behalf of the Neurocritical Care Society, thanks for listening.